Hello, everyone. My name is Florim, and I have the great privilege to co-chair this symposium with Dr. Brilakis. We have a really great crowd today, and I'm happy that we have so much people here. And I'm happy that we have 4 fantastic speakers for this. Maybe just one sentence why this is important. I think in treatment of calcified lesions, there have been never more choices than we have nowadays. And choosing the right device or combining the right devices is challenging. And I hope that today we can discuss and find out the proper way to treat our patients with calcified lesions. I'll now hand over to my co-chair, Dr. Brilakis, to introduce the speakers, and then we go on, and hopefully we have a lot of fun. Thank you.
Wonderful. Thanks again, Florim, and welcome everyone. This is going to be a great experience for everyone. We'll have an amazing panel. Dr. Darshan Doshi from Mass General. We will have Nachiket Patel. Dr. Stephane Rinfret, Dr. Natalia is coming in a few minutes. But this is a technology we haven't been using as much in the US, and I think there's a lot of things for all of us to learn from the experience both of Dr. Cuculi, but also from the other operators in the US who've been pioneers and working on this all the way. So we're going to start with Dr. Doshi. He's talking about clinical challenging in complex PCI and In-Stent restenosis. Darshan, thanks so much.
All right, thank you so much for having me here today. And I have the distinct pleasure of talking about some of the clinical challenges that take place in complex PCI and In-Stent restenosis. These are my quick disclosures. So one of the issues with severe calcium is the fact that it's present in over 30% of our PCIs. So it's a lot more ubiquitous than we actually think. So if you look at this study from Acuity and Horizons AMI, which looked at the use of bivalirudin for ACS, you basically found that approximately 30% of patients had severe calcium. And if you look at the syntax data, the more complex the coronary anatomy, the more likely you are to have severe calcium. So in the syntax trial, if you had left main or 3VD, that number shot up to about 50%. And one of the things that we know is that calcium changes the risk profile of the procedure. So it increases the safety risk. There's a higher risk of perforations and dissections. It also impedes our ability to get our gear where it needs to go. It can impede our ability to get our stents where they need to be, and moreover, it prevents appropriate expansion. We know that minimal stent area is the #1 driver of whether or not a stent is going to fail or succeed. Now, if you look at the clinical data, so don't just take my word for it, but there have been multiple clinical trials that have looked at the presence of severe calcium and the effects it has on outcomes. So this is one such trial by Samin Sharma called the MACE trial. And what you may notice is that in patients that have severe calcium, what you find is that the MACE rate, the major adverse cardiac event rate, is nearly 25% at 1 year. So 1 in 4 patients with severe calcium will have a MACE event. Now, there's multiple different modalities that can be utilized. And the way I think about the different treatment modalities are to break them down by balloon-based technologies and atherectomy technologies. So the most commonly used device for dealing with severe calcium is actually an NC balloon. But scoring balloons, cutting balloons, the use of IVL have sort of changed the paradigm for us. And then there's also the use of atherectomy. And there's rotational atherectomy, orbital atherectomy, and laser atherectomy. Rotational atherectomy has been around the longest and has the longest body of data. Now, what we didn't have in the US until recently, as Dr. Brilakis mentioned, is the use of the OPN balloon. So the OPN balloon is a double-walled balloon, and it's exceptionally deliverable, but it's also a low-profile balloon. And the unique aspect about this is that every balloon has a rated burst pressure of about 35 atmospheres. Moreover, every balloon has been tested up to 42 atmospheres from bench testing. So what we do know about the OPN balloon is, 1, you can go up to 35 safely, and off-label uses you can go higher. What we do know, and some of the other presenters will talk about the data that shows you the lower risk of dissection perforation with it, but it's very effective in getting luminal gain with severe calcium. And so if you look at these clinical cases here, what you see is that there's a calcific ring, and essentially after the use of an OPN that you have the cracks and the expansion that you really want. And so an area where OPN really works well with severe calcium and de novo disease is when there's a calcium ring. So let's just show you a case. So this is a case of a patient who came in with stable angina, had a positive stress test in the inferior distribution. And what you can see essentially is that there's a area of stenosis in the mid-right coronary artery. Now, the operator tried to expand this by using an NC balloon. So they used an NC balloon, and clearly you see that there's dog boning. So multiple operators may just lean on it, go with a larger size balloon, or go way past rated burst pressure in order to crack this calcium. So what we did was we just used a OPN balloon. And one of the things with the OPN balloon that I do is basically undersize it by about half. So if it's a 3.5 vessel, I'll use a 3.0. If it's a 3.0, I'll use a 2.5. Because once you get to the higher ranges, what ends up happening is that essentially the compliance changes. And so I start off by undersizing it by half and then subsequently going up. And what you can see is when you use the OPN on the first inflation, waiting less than 10 seconds, the waist expands and there's no issues. And then this is the final result. No headache, no issues, no perforations, no dissections. Now, another area where OPN has been particularly useful and how I first got experience with OPN is actually an in-stent restenosis. And so what we do know is that 10% of all PCI is done for ISR. We also know is when we compare outcomes for patients that have ISR compared to de novo disease, that they have a much higher MACE rate. So this is an analysis done by Hector Tamez and the team at the Beth Israel, specifically looking at the NCDR database. What they found is that there was a 10% increase essentially at 4 years with ISR compared to de novo disease. Moreover, if you look at all the different key outcomes, if you look at MACE as a whole, death, MI, and target vessel revascularization, they're all statistically significant with worse outcomes for ISR PCI. So this is an area that obviously we need to tackle and do better. So how do we manage in-stent restenosis? So the first thing is to always define the etiology of why the stent failed first. And the use of intravascular imaging is particularly paramount. The second is then to use the appropriate modalities, so we have to be able to treat it and take care of it. And I think that OPN has been a particularly strong addition to the armamentarium to be able to take care of ISR. And then subsequently, you want to then treat it with either accepting a POBA result, potentially restenting, or using a DCB. So when it comes to the cause of ISR, you really have to use intravascular imaging. I don't think it's sufficient enough to just use angiography. And the 5 most common causes of why patients have ISR, and frequently it's not just one specific pure reason, but typically it tends to be a few of these reasons. But things like neointimal hyperplasia, calcific neoatherosclerosis, stent undersizing, stent underexpansion, as well as stent fracture. But in 2 areas where I think the OPN really works well for ISR treatment is with calcific neoatherosclerosis and stent underexpansion, particularly due to calcium behind the stent. So this is a case of a patient that is post-CABG, has had recurrent interventions to the circumflex artery, and you can sort of see that clearly there is an area of restenosis at this area. And so when we do intravascular imaging, what you essentially find is that there's 2 areas of, there's an area of underexpansion where there's 2 layers. There's another area of underexpansion with neointimal hyperplasia, and then there's an area that has minimal neointimal hyperplasia. But underexpansion is the cause for why the stent keeps failing. So one of the things that I typically like to do when you have multiple layers of stent is to start off using laser atherectomy. And so we use a 1.7 Elka laser. We used contrast. We used saline only to keep it on label. And then with that, there was some sort of luminal gain, but not substantial. But what the laser does is that actually softens up the tissue, so then you can then go in and use your OPN to then be able to deliver what you need to. And so again, I think it's a 3.5 vessel here, so I half-sized it down to 3.0. I think the proximal is at least a 4.0. And so subsequently, we used a 3.0 and 3.5 OPN balloon. Much better expansion. And then followed it up with the DCB. And the imaging showed that there was appropriate expansion. We had greater than 80% expansion compared to the distal reference. So just to conclude, calcium is a lot more ubiquitous than we think it is. It's more than 30% of our cases, and with more complex anatomy, that number shoots up to about 50%. And we really need to use all the tools at our disposal to be able to take care of this. And the other issue is that when it comes to ISR, and more than 10% of our cases are due to ISR, and what we need to figure out is the cause of why that transpired. So the use of intravascular imaging, I think, is paramount. But the two most common reasons are neoatherosclerosis and calcium behind the stent resulting in underexpansion. And the OPN can be a very safe and effective way in both de novo disease as well as ISR to achieve luminal gain and stent expansion. Because again, at the end of the day, the minimal stent area is going to be the biggest predictor on whether or not a stent is going to fail or work. Thank you so much.
Thank you. Thanks again, Darshan. That was a great presentation and a great overview. And I guess for many people, maybe a show of hands, how many people in the audience have used the balloon, the OPN balloon? Okay, so maybe 20, 30%. So the majority have not. And I know that it's going to be covered again in the other talks, but it's always good to start with the basics. So what is your technique for the OPN balloon? Do you undersize, as you mentioned a little bit? How do you deliver it? You go at 35, you go at 40, 50. How do you typically do your case? What wire do you use?
Yeah, so there's a couple of things about the OPN that you have to understand. One, it is a double wall balloon. It's deliverable, but it is like a NC balloon. And so what you really want is if you can get an imaging catheter, you can typically get the OPN. So you really want to test with an imaging catheter first to make sure you can deliver it. If you can't, you can use a guide extension. So that's an issue with delivery. The second thing to talk about is the fact that the OPN, when you expand it, so I typically go, again, rated burst pressure is 35, but all the bench testing is up to 42, and you can take it up higher than that if you need to. So I've taken it up to 50. Haven't had any issues. I haven't had a perforation. But one of the things is when you start to go past the rated burst pressure, the balloon, the inner hypotube, can kind of cinch on the actual wire. So one of the wires that I think you should avoid using is a Xi'an blue. The coating interacts with a lot of different balloons. But if you do go up higher, what I typically do is always have a buddy wire. And so I use the buddy wire. I then have a wire where I deliver the OPN balloon, and if it seizes on the wire, I can take the balloon as well as the wire out, and I still have access to the distal vessel. And again, when it comes to sizing, you really should be using intravascular imaging, and I just go a half size too.
Maybe, do we have any questions from the audience? Maybe a quick question from the audience. If there's a question for Darshan, please go to the microphone. Very quick question.
Thank you for your presentation. I'm asking about also the types of the duration for the balloon inflation. If there's any tips different from other balloon inflations regarding the duration?
Yeah, so I think one of the things that I think we don't really appreciate is that a lot of the times we think of just the total atmospheres that you're able to generate, but there's also a time component. So it's not just the actual force you're able to generate, but it's the time aspect as well. So typically I just go up until I see appropriate expansion and there's no waste, and then you could take it down. You don't have to keep it up indefinitely. You just wait till you actually see the waste give.
And if I can add, Darshan, in treatment of in-stent restenosis, what I do is you go to a certain atmosphere, you see the balloon is open, but then the balloon starts to lose pressure because it further expands. And then you just refill, because then I refill it. You do it like that the same?
Exactly. I was about to comment. So exactly, you got it right.
And so I think that's also important. That will take a bit of time, but it will gain you lumen, because otherwise in ISR, if you don't get lumen, then you will not have success.
Yeah, and another characteristic is like the balloon inflates a little bit slow, right? So I usually go like 4 by 4 by 4 by 4 and see how the balloon is behaving in the stenosis. And as you guys are saying, once you lose the weight, then you refill and then you come down.
One more question.
What's the difference between the OPN and the cutting balloon?
Well, so the cutting balloon typically has a scoring element or a blade or an atherotome. With OPN, you don't have the blade or the atherotome, but what you do have is a double-walled balloon. So that balloon can expand to much higher pressures than an atherotome-based balloon or a scoring balloon can. So there's no cutting element that's attached to it. It's just a double-walled balloon, but just allows you to go to much higher pressures.
Wonderful. Thanks again, Darshan. Great presentation. And we'll move on to Dr. Nachiket Patel. He's going to talk us about innovative approaches, the clinical evidence, and some clinical applications. Nachiket, thanks so much.
Thank you. All right, hello everyone. My name is Nachiket Patel. I'm from Phoenix. Thank you everybody for coming, and thank you for the opportunity to present my experience with the OPN. These are my disclosures. I'm just going to start with presenting a couple of cases. The first case is of a 76-year-old female presented with an N-STEMI, and I was taken to the cath lab, and here you see the caudal and cranial projections, where you can see the LAD is diffusely diseased in the proximal to mid portion. Of note, the interventionalist didn't use imaging to guide the intervention. So after pre-dilating with a 2.25 millimeter balloon, a 2.25 by 38 millimeter stent was deployed in the mid-LAD. The proximal portion of the stent didn't completely expand, but that was not recognized. Another 2.5 by 30 millimeter drug-eluting stent was deployed in the mid-LAD, and a 2.75 by 12 millimeter stent deployed in the proximal LAD. I suspect that the interventionalist didn't recognize that the underexpansion, and he or she thought that the underexpansion was due to the fact that the lesion was missed. As a third layer, a 2.5 by 12 millimeter drug-eluting stent was deployed in the mid-LAD. The patient was, these were the final results of that intervention. The patient was discharged the following day, but not surprisingly, continued to have CCS 2 to 3 angina. 3 months later, the patient was referred to me as a second opinion. I had opportunity to review these prior films and to think about how I'd approach this case before taking her to the lab. I considered laser atherectomy, which I think is a reasonable option. Orbital and rotational atherectomy, I think less ideal, mostly because the need to place another stent, which I didn't want to do. Orbital atherectomy, as you all know, is off-label for in-stent restenosis. I don't mind using it, except for, I was a little more cautious because these stents are relatively new. Rotational atherectomy has that risk of no reflow, or more importantly, burr entrapment. And the procedure would have taken a little longer, in my opinion, if I were to stepwise increase the burr size to decrease the chances of burr entrapment. Intravascular lithotripsy wasn't much of a consideration for me because I thought that it would be, I didn't think I'd be able to deliver the balloon in this case. Additionally, while I think it works excellent in when you have severe concentric calcification, and it's worked great when I've had underexpansion due to one layer of stent, I haven't had much success with underexpansion because of 2 layers of stent, and so certainly I didn't think it'd be optimal at all for this case with 3 layers of stent. So what I thought was I'd use the OPN balloon. And as Darshan mentioned, it's a super high pressure, non-compliant rapid exchange balloon designed to treat highly calcified and non-dilatable lesions. It has a low profile. It's double layer, reduces the risk of not only balloon rupture, but also allows for it to be very non-compliant. It has a linear compliance curve up to 40 atmospheres. I was a little surprised that despite all my tricks, I wasn't able to get anything past this more proximal lesion indicated by the arrow. So I next went to using a 0.9 millimeter laser at 80 fluents and 80 pulses per second. I typically, when I do laser, I will use laser on contrast. And to cross the more proximal lesion, laser was done with concomitant administration of 70% contrast, and the more distal mid-LAD lesion, 100% contrast. Total treatment time was 180 seconds. So after laser, I was able to predilate the LAD with a 2.5 by 20 millimeter semi-compliant balloon at 20 atmospheres. OCT was performed next, which, despite the predilation, still shows a minimal stent area of 1.19 millimeters squared in that more distal lesion. I took a standard 2.5 by 12 millimeter non-compliant balloon at high atmospheres, but as you can see, there's still a significant waste. But a 3.0 by 10 millimeter OPN balloon at 35 atmospheres yielded the lesion nicely. So final angiograms here show pretty good results. OCT after the intervention. So the proximal to mid LAD was then post-dilated with standard 4.0 and 3.5 millimeter balloons. And OCT afterwards shows a minimal stent area of 4.5. Pretty good improvement from 1.19 where we started. Second case I want to show is that of an 83-year-old male with a history of TAVR 2 years prior, presenting with an N-STEMI. Diagnostic angiogram, you guys can see that the left main is kind of hanging on by a thread there. I pre-dilated with a 3.0 by 15 millimeter balloon at 20 atmospheres, but there was still a significant waste. IVUS after that showed heavy concentric calcification. And while I don't have the image to show you here, I used a 3.5 by 10 millimeter OPN, which balloon that yielded the lesion, and then stented it with a 4.0 by 12 millimeter stent, post-dilating it with a 4.5 millimeter balloon. So a couple of cases of my experience. I think the OPN balloon works very well for heavily calcified concentric lesions, but then it begs the question, you might be wondering, how does it compare to other balloon technologies, specifically intravascular lithotripsy? So I just have a few things that I think of when to help me with my cases. And in terms of deliverability, I think the OPN is superior to the delivering the lithotripsy balloon. While I think both work great for focal lesions, I think the edge goes to the OPN in diffuse lesions. As you all know, intravascular lithotripsy, the balloon length is 12 millimeters. The OPN balloon, the length goes up to 20 millimeters. Additionally, as you go up with the balloon, you can see the lesion yielding with the OPN balloon. Whereas I often find that because the intravascular lithotripsy balloon inflates at 4 atmospheres, you often don't see whether or not the calcium was modified until you go back in with an NC balloon to see if it properly expands. And so for both of those reasons, time-wise too, I think the OPN balloon allows for effective and faster treatment for some of these more complicated cases. So in conclusion, I think imaging is important before most interventions, all interventions really, specifically to expand that calcium and also that way preventing those kind of situations where you have stent regret. The OPN NC balloon offers a versatile solution for severely calcified and non-dilatable lesions. It has a good safety profile and should be considered in de novo calcific lesions and in-stent restenosis due to stent under expansion. Thank you for your attention.
Thank you. Thanks again, Nachiket. Great presentation. It's very interesting. Usually we say you have to do intravascular imaging to make sure. But in the first case you saw, it was so obvious that the stent was narrow. So it's not all, you don't always have to do intravascular imaging. Sometimes if you look at the angiogram alone, there's the stent boost, all these modalities to look at the stent. You can actually see the stent under expansion fairly well. So it was a good thing the patient did not restenose. But first of all, any questions from the audience? Yes, please.
Why the rate of dissection and perforation is low on this particular balloon?
I beg your pardon?
Why the rate of dissection and perforation is particularly low on this balloon?
And I think the others will speak to it as well. But in my opinion, I think it's because as Darshan said, in in-stent restenosis, I use a 1-to-1 size balloon. But in de novo lesions, I do decrease the size of the balloon by half. Additionally, I think it's the volume that causes. So certainly, if you have a nodular lesion, perhaps it might not be, the OPN might not be, like if you have a nodule of calcium jutting into the vessel, the OPN balloon might not be the best option. But I think if you have concentric calcification and the super non-compliability of the balloon, I think it's the volume that causes perforations, not so much the pressure.
Absolutely. I think it's very important to recognize, and I speak now of almost 15 years of open NC experience. Vessels are being perforated by diameter, not by pressure. If you inflate a 10 millimeter balloon in a 2-0 vessel with 2 atmospheres, you will perforate it. You can inflate a small balloon in a large vessel, nothing will happen. So it can't be pressure. And I think Well, I don't agree with you is on nodular calcium, because even in eccentric calcium, the diameter control you have with this balloon, because with this balloon you can go at high pressure without your diameter exploding. With a normal NC balloon, very often if you go beyond 25 atmospheres, the diameter increases massively and then it becomes dangerous. The open NC remains in this linear curve even if you go beyond 40. So I think in nodular calcium, you just have to respect the nodule and not to overdo it with the diameter of the balloon, but you can still create a lot of space with an open NC balloon. Maybe.
Yeah, I think I had the same experience. I don't think the risk is low if you know how to use it. So we are going to show cases at the end of the session today from all the type of calcium and how the balloons behave, because now we had some data with imaging. I think in the past we were using this OPN balloon without understanding exactly what it did, but now we are invested on intravascular imaging, understanding what it did. So actually with efforts of some people here, including Florim, we have used it in nodular, sheath calcification, concentric, eccentric. So now we are getting some insights, how does it work? And I think if you undersize innated vessels, I have used it for many years and I have never had a perforation. So I think it's the way you use it.
There is another question.
Actually, my question was, she said that the criteria of calcium which make us anticipate or predict the success, I think it will be presented at the end of the session. Yeah.
Wonderful. Thanks again. Thanks, Nancy. That was a great presentation. And moving on to the third talk, this is Stephane Rinfret, who is going to talk about safety. Again, one of the concerns people have is it safe to go 35, 40, 50 atmospheres? And Stephane will give us the answer.
So I think it's important to talk about the safety, but also why we need this balloon. You need this balloon because reality is IVL does not work alone, and most of the time you need adjunctive therapy. Under expansion can occur despite the best intention, and I'll show you an example of this. The high pressure without balloon burst is safe, and especially without balloon expansion or overexpansion. That's why we need safe solutions for cases. But the truth is that I'm not a big fan of or. I think in these cases it's more an and. You need to have a full toolbox to be able to use what needs to be, and it's often by testing one modality and another one that you will be able to achieve the treatment that you need to do. And before stenting, while these modalities are really popular, and now OPN becomes more popular, for under-expansion stents, OPN, and for fresh under-expanded stent, OPN becomes very, very attractive. But again, it's not about first to use in my perspective, it's about having all the tools. Here's an example, and I'm not pulling examples from 3 years ago, the two examples are from last week. So Savers 2 years ago, non-obstructive CAD at the time. He had a PCI at the years ago. And the LED stent right there is not grossly underexpanded, but something that may explain why the patient has angina. So we did an IFR, and it's positive in both branches. So clearly, I think it's where the problem. Start with an NC balloon at 20 atmosphere, and you can see that the 3.0 balloon is not expanding. So, however, at that time, I'm able to bring an IVUS. I'm just showing the date, so I'm telling you the truth. So here, this is the area where it was the tightest. You can see that there's neoatherosclerosis. You can see that the stent is right here, and you can see a spot of calcium inside the stent. So it's an old story that you're gonna have to treat with new toys. So here's IVL. And you can see it's much better expansion that the balloon did, the 3.0 balloon, but it's not completely expanded, and afterward, I just right away went with an OPN, and I inflated up to 45 atmosphere right there, and I got a much better expansion on the balloon. Once this was done, I did IVUS again. I will show you here in the area where it was like grossly underexpanded. You see now that the old stent is right there. You can see speckling of neoatherosclerosis inside, but especially in the proximal segment right there, you will see that there's like nice fractures all around, and the neoatherosclerosis has been taken care of. Then it was, the whole idea is that I undersized because the vessel's 3.5, so you use the 3.5 NC. And at this point, I'm not satisfied with the expansion of my 3.5. You know, of course, I'm not going to bring another OPN at this point. I could. It becomes a bit expensive. So I'm going to just try to beat this up with an NC. It doesn't work. And then what about a scoring balloon? And then the scoring worked beautifully at this point. It was able to expand completely. And then finally, we got a very good result. And IVUS again. And you will see now that the expansion is much better. And this is all based on evaluating your IVUS prospectively and testing one modality over the other and after the other. And then now I'm very satisfied and I'm ready to go and use another stent. Here we could have argued for a DCB. However, I yet don't have DCB in my center, so that makes the choice easier for me to use a stent for now, but it's soon to be corrected. So we placed an onyx, and again, I think it's reasonable because it's a second layer here. We post-dilated, and this is an arterial dysuria, by the way, and this made that procedure a bit painful. And then we got very, very good expansion of the stent. So the new stent now is big. It is large. We had an MSA that's over 7 millimeters square in that mid LED, and we got a very good result. So message, I needed a lot of tools to make things happen, and it's not about what you use. So I think in the end, you could argue, did I have to use IVL? Could I have started right away with OPN? I think experience will tell if this is the right way to go. Okay, underexpanded stent when they're just freshly deployed can occur despite the best intention. So this is an SVG that's thrombosed. You can see that long thrombus here. It's going to a D1, a ramus, and there's a 4-0 stent jailing that diagonal. So I think we're all understanding that there's got to be a fight here. It's not going to be easy. So I'm getting there. I'm getting retrograde. I'm doing a knuckle. And this knuckle is in beautiful position. I bring antegrade gears, and I have to pierce the stent with an Astato 20 finally. And then I try to wire retrograde with a guy. It doesn't go. I go back antegrade. Why I'm showing this is because I get more fatigue, right? I'm working hard. And then the stent is sometimes like you're so happy you've achieved everything. Now you put the stent, and that's going to be the most permanent thing you're going to do in that patient, right? Is implanting the stent. So at this point, I'm happy. I have a wire going in. This is an Astato 20, and it's going, and it's dancing with the other vessel. I'm happy, like an Italian with wine. And I have here a bit, I'm exchanging for a wire, another wire. This is a Mamba here that couldn't cross, but I'm going with a Mongo. And now I own this vessel. I'm super happy. Reverse cart, exchanging, wires down, we're good to go. Ballooning, I look at the balloon, I said like, it's not expanding, but it's only a 2.0 balloon. Let's just use a bit higher pressure, and this is the IVUS. So, and I think I ignored some of the data I got. So this is plaque, this is the old anastomosis. You see the wire on the top. So we're coming back proximal right there. And you see that we crossed extra plaque. So we're in the subintimal space at this spot. And you can see on the right side, there's a big shadow right there. So there's either nodular calcium or it's just because I'm completely subintimal in that zone. Felt a bit like, I think we're fine. We've opened things okay. And then I used the 2.5 balloon. It's not bad, it opens. And then get the stent in, and I don't like that. I'm not happy. Put the stent there, and then pot, and then I come back with the 2.5, and I don't like the way it looks. And IVUS will confirm that this is not good at all. This is the worst spot right there, where you have like that shadowing behind, and you have like an area that's about 3.5 to 4 at this spot. So OPN is fantastic. So it just got there. I blew it up to 45 atmosphere, and I really got a big difference in terms of area right away. So, and why did I make that mistake? Well, you're 2 hours and a half down into that case, you're super happy, you dropped the stent there, and you didn't foresee something because it was not overly calcified, but I bet this stent would have restenosed. And with the OPN, very nice expansion, and we did the kissing, and then afterward, I want to show you the IVUS. That is, it's clearly better expansion that you can see all the way in that area. And finally, we're able to open the native. So why did I show this, and why I want to finish with the fact that it's safe? It's because you need all the tools, and you shouldn't be afraid of your OPN, because your OPN is going to be your friend. And in 326 undilatable lesion, that's the largest series so far published. They only had 3 patients that had perforation, and there was no difference between more than 40 atmosphere or lower. In the most recent SKY consensus on the management of calcium, they remind us that we have only single center data and mostly without comparison group. But using a 0.5 smaller balloon and using a 1-1 strategy for post-lesion is recommended. It is considered to be safe. And my friend Manos Brilakis shared with me some unpublished meta-analysis data of 11 studies, including prospective single-arm cases where actually the perforation rate is 0.6%, which is quite low when you think about using this balloon. So conclusion, OPN can achieve old and new stent expansion in several scenarios with NC balloon atherectomy, IVL, and it is safe for pre-stenting in several single arms, but I think we need more comparative data with the newer and other modalities. Thank you very much for your attention.
Thank you. Thanks a lot, Stephane. I have one question. You mentioned it's not or, it's and. So if you can choose one partner for the OPN, if I was your hospital director, would tell you, you can choose the OPN and one other device, which one would you choose in treating calcified lesions?
Yeah, I think I would say that if you have OPN, you need some ablative therapy. You cannot. I think I would keep the balloon based and the atherectomy based as being very, very different. Of course, but I think it has OPN and shockwave have taken a lot of the market of orbital. I think orbital is less attractive nowadays that we have balloon-based therapy that can achieve the same plaque preparation. Rotational atherectomy still has this feature of being used for uncrossable lesions and other situation, and I think it has been there for so many years that I would be very uncomfortable not having rotational atherectomy in my armamentarium of what I'm doing. But again, if you're asking me what could you work with in the future, I'd be hesitating between shockwave and OPN. I'll be truly honest to you.
Okay. Thanks, Stephane. Great thoughts. And if any questions from the audience, in the meantime, one more question. So it looks like you did the OPN in the extra plaque space, subminimal, right? And people get nervous still about you doing into the subminimal for any balloon, especially a higher pressure balloon. So do you go a little lower pressures in the extra plaque space, subminimal, or how do you handle that?
Yeah, well, at this point, I was sort of guided. I think it's also based on, how much you incremental. So I went first with a 30, and then afterward came back with 35. So I tested a bit the resistance of that vessel, and I know that, it was progressively. I didn't have like an overexpansion of the balloon, and I think it's one that is something that we just makes us very unhappy or uneasy with PCIs when you're using pressure, and all of a sudden you're going on fluoro and cine, and then you see the balloon looks like a gigantic where it was not earlier. So this is something you don't see with OPN. It doesn't give you that frightening moment of seeing a balloon too big, and you know what's going to happen when you deflate it.
And Manos, maybe one point I can add for the audience. If you deal with circular calcium, very often in my lab, we don't look at the size of the vessel, but we check the inner size of the ring if you have intravascular imaging.
Okay.
The vessel can be 4.5 or 4.0, but maybe the inner size of the ring, the diameter is 1.5. So to crack that ring, you don't need a 3.5 balloon. You can crack it with a 2.5 balloon, exactly. So then you just go to very high pressure, and you have a safety margin which is better than in any other calcium treatment therapy. So I think that's why it's so important to have such meetings to exchange these experiences. Do we have any other questions from the audience? Please.
Thank you. My name is Henry. I'm from Indonesia. I want to elaborate more about the statement of Dr. Brilakis, actually. In our country, more than 95% hospitals do not have imaging facilities. So Dr. Brilakis said that we can use the stent boost. How sure can we use this stent boost to evaluate the deployment of this balloon in your experience? Thank you.
Yeah, thank you. Great comment. And actually, it's true that, I mean, you don't have the imaging for other reasons, but many countries that do have imaging still don't use it. So it's not just that part. But it all depends on the visibility of the stent and the amount of calcium. So the issue there sometimes can be if you have too much calcium, and if you have a thinner strut stent, you may have a hard time seeing the stent strut. But using the stent puts, clear stent, any of those imaging modalities, especially if you do it on two orthogonal views, can really play a huge role. There's actually a study on CT-guided P4 where they use the stent expansion by X-ray as a primary endpoint. So it can be fairly accurate, but we've had some cases when it's extreme calcium and you have a hard time seeing the stent struts, and there it can be less reliable. But like in the case that you saw from Dr. Patel earlier on, I mean, sometimes you can see clearly, hey, the stent is big, and then all of a sudden it narrows down and then gets big again.
Can I ask one quick question?
Okay, one last question.
Going back to imaging, is there any field for thickness of calcium and the ability of OPN to crack calcium on the basis of thickness?
Any thickness. That's my
Perfect. Well, that's actually what Dr. Pinilla is going to answer in a second here. So, Natalia, thank you so much.
It was great. So I'm here with a lot of CT operators. I'm following Stefano. It's not easy because I'm going to be following Mongo, Mamba, Knuckle. So I knew this was going to happen. So thanks for the opportunity to be here. And I think my job now is to show you in cases, however, my colleagues already show you some interesting cases. And when we got this balloon in our auctions, we didn't really know what to expect from this balloon. So I have to say we have used it pretty much in all type of scenarios. So that's why I'm here to share my experience with you. So there is this, the circumferential superficial calcification is one of the worst fears we have because most of the calcium is inside the lumen. So the first example is about young patient with risk factors and unstable angina. And if you see here in the right side, like the OCT image, this calcium, the thickness is 1.5 at least, and it could be thicker than this because the field of view of OCT is not that much. So what is the thickness you can modify with this balloon? I will say any thickness. I think what is important is what is the lumen and what is the vessel size, because once you use this balloon, you're gonna see the modification that comes from this. So the minimum lumen area was very small, 2.43, with circumferential thick calcium. So these are the lesions right now that we are mostly addressing with IVL, for example. So you see, once you use an OPN, this vessel was very large, was like over 4, so we use a 3.5. And as Florim was saying, it's not just about the size, it's about just something that fits in this lumen. And you see the fractures that come from this balloon. They are very wide and very deep calcium fractures. So this is very similar to the modification we get with IVL. So indeed, you may need 1 or 2. Maybe just with 1, you can achieve like the area you want to achieve. So just make sure you undersize, because if you imagine these fractures and these dissections, if you oversize your balloon, that's when the complications are gonna come. So then a stent was deployed and you got a very good MSA with an expansion over 80%. So this is how this balloon will work in a circumferential thick calcification. So before we had some questions, what about the nodular calcification? And we have been impressed how good this balloon is actually nodular calcification, because I think the high pressure helps to get the 3 different types of modifications. So you get vessel expansion, you have fractures, and you also create dissections. And as Florim was saying, the NC balloon is not as strong in the calcific side. So when we use an NC, it opens in the opposite side of the nodular calcium. When you use an OPN, actually opens circumferentially, like modifying this nodule. So you see here in the middle screen how these mountains of calcium are really protruding into the vessel with a very, very small lumen. And when you use the OPN, you see again, like all the modifications. The vessel looks larger, so you have luminal gain. You have vessel disruption, fractures in different places. So the OPN is a great, great tool for this nodular calcification, and works not just for concentric, but also for eccentric calcium. So here, after deployment of the stent, like an area of 10.8 with very good expansion was achieved. And remember, the stents in calcium open like that; they don't open exactly circumferentially, but eccentrically. But once you achieve a good expansion, that will be good enough. Cases about underexpansion, we had seen quite a few from the previous presentations, but this works as any other device we had available in underexpansion, and I think that has to be very clear in our practice. Once you had an underexpanded stent, this is probably the easiest to get there, the safest to get there, and you as Stefano was saying, you don't get frustrated when you use this balloon because you put it there for a reason and it's open in this stent. In this case was underexpanded with 64% expansion. Once you get it there, in this case, you see the measurements we did, we see the very poor expansion. You have a sense that this stent didn't open because nodular calcification in the background. Once you use an OPN, it opens the lumen in an eccentrical way, and you get an MSA of 10.6. So this balloon gets the job done, exactly what you want to achieve. It gets it done. So here we see how now the OPN display this nodule calcium to the back, and you're achieving a good area. So this calcified neointima, and I have to say, when I was doing my training in the beginning, it was really hard for me to believe that actually the calcium grow inside, like some of the new atherosclerosis become calcium. And this patient had an old PCI, had a failed Lima graft, and then we had to go after this stent that was completely underexpanded. And this was one of the most beautiful cases I remember, because it was the first time that I became really, really conscious how bad the calcium can be inside the stent. Here we cannot even, it's very even hard to see all the strats, because once the calcium builds in layers, some of this calcium creates some attenuation, and then you don't see the stem. So it's all concentric calcified neointima. And again, for this setting, it's actually very impressive the way it works, because you had a stent in the background, so there is no much chance of complications here. Going back to the thickness, just see how thick is this calcium. It's at least 1.7 from the stent strats in a very long segment, over 5 millimeters, and that's a good advantage of this balloon, that this balloon doesn't burst. So you can use it as many times in a long segment, and I think that's a very important feature of this balloon. So you see, once you use this balloon, you create these dissections beautifully. I think I'm not lying if I said you almost get like a stain-like result inside this calcified neointima. And every time I use this balloon in this setting, you feel like you don't even need to put a stent, because it's like you really modify this calcium that grows inside. You get a stent-like. Now we have the drug coating balloons. Can you give me more time for the presentation, because I started late? So can you just go back in? Just continue.
Yeah.
No, because they put it back. So I need. So just going here. Yeah, this is a very satisfying clinical scenario where this balloon really works for these cases. Some people say, okay, how safe is this balloon? We have used it in vein grafts, in limas. We have used it everywhere. And we had used it everywhere. And honestly, I really, okay. And even in this case, that was a very old patient, 88-year-old female, admitted with NSTEMI. you can see how this is the job we do when we do a quick PCI guided with angio. Someone put here a few months before a stent without any modification, and you see how this stent couldn't open because there was a lot of nodular calcification inside this vein graft with a very small diameter and very, very underexpanded stent. But once you use, if you have a sense how much of these nodules are avoiding this stent to open, once you use a good size OPN, you get a decent area in this segment that in this setting, I will say nobody will have used any other device. So this is like a very important place where we can really consider these balloons, because if you size it well, they are very safe to use. So we wanted to say that now we don't understand. So suddenly we had in the past on other balloons technologies for calcium, all of them are deployed to 4, 6, 7 atmospheres. And out of the blue, we got this balloon that we can inflate to 40, 45. So now we don't know where to place this balloon. Is the OPN balloon as an NC? Is the OPN balloon as an IVL? And we don't have like randomized data. So we are working, and Florim is one of the leaders. His size is the center that is leading this study, that is the Victory trial that is comparing the OPN to the IVL. Again, aiming to understand how this is compared to other technologies. We are like halfway recruitment, and we also know there are other trials on this field. So I think very soon we are going to have randomized data in this setting. So tips and tricks, I would say before this, Stefano said it before, don't be afraid to use this balloon. Size it with intravascular imaging or your tools, your stent boost or other tools, always undersize compared to the mean lumen diameter. Don't use the EL, measure your lumen and undersize from that. And I will have to say, like, yeah, we feel very excited about going to 40 and 45. And in Europe, they had like a 60 atmospheres insufflator. Most of the times, you don't need like very high. If you pick the size balloon, 28, 32, at a good inflation and waiting for the time of modification gets the job done. Be careful with your wire. You may lose your wire. This was already brought up. Inflate slow, go 4x4 and see how your balloon behaves, and avoid using other dedicated balloons in combination. So in native vessels, don't get an IVL, OPN, and NC side head pressure, because then that's when the complications come. And post-PCI, we also said this before, use the same stent diameter, no bigger than this. Usually you don't need, it's not like this, like the NCs that we put a 4 and then we use a 4.5. For this one, is the same in post-stent and is undersized in previous stent. So OPN is a tool for native calcific lesions, lesions that cannot be open in stent restenosis and stent optimization. And intracoronary imaging is important and is recommended, but we also acknowledge some other don't have this available. And now it's important we have randomized trials that will give us more insights about how to use it, how safe it is, and how effective it is. Thank you.
Wonderful. Thanks, Natalia. Again, one image is worth 1,000 words, and sure enough, so many pictures are worth many million words. So I think that makes very clear to the mechanism of action. Actually, I see in the audience the Eurocity president, Dr. Masayeki, who is actually a big experience with this balloon. I'd love to hear your thoughts as well.
Another Mamba Mongo, Nako.
So thank you very much for this clear presentation. We have a lot of experience over many years, as Florim as well. So there's one important safety aspect. Whenever you have an NC balloon and you have a ring calcification circular, it's very, very safe to use that balloon. When it comes to eccentric and calcified nodule, further plug preparation might be useful. At the moment, the best modification tool that I have, for example, for eccentricity, especially when you see the ostial circ, is a combination of the shockwave first, modify that, deep calcification as well, and then go with the open NC. So the open NC can be very, very safe. So we have a very large intra-hospital database, over 15,000 PCIs in 5 years. We used it in 3.5% when the NC didn't open, so around 540 cases. Perforation rate was 1.7% versus 0.8%. So we had higher clinical relevant perforation. But pericardiocentesis was almost zero. Why? Because we almost used it in circular calcification. We always had a body wire inside, And when you see birth in circular calcification, then you just exchange very fast to an additional cover stent, and you're done. This is different when you treat that with eccentric calcification, because you just rupture the nodule outside, and that's a big mess. So when you start to learn with this balloon, take 2 wires, take concentric calcium, spot circular calcification, be relaxed, go up with the atmosphere. It will be very safe and efficient.
Thank you so much, Combis.
Yeah, thanks. I think it's always great to hear the knowledge of experience, but also part of it is the sizing. I think Natalia made a great point. If you have a 4.0 stent or 3.5 stent, don't go with a 4.0 balloon. Okay, that's the big thing. When it's de novo, once you've heard already, I think from Darshan and Nachiket Patel, is that you go a little smaller. You go half a millimeter smaller. Florim, I know you have also humongous experience over the years. What are your pearls of wisdom? Like, I know we talked about them a lot, but any specific things on the duration that we're talking about? How many times would you use the balloon? I mean, if you see expansion, are you done? Would you use it again? What are your thoughts?
Of course, the balloon, it's when I do proctoring outside Switzerland, the first thing I check is, do they have an OPN balloon? Because then I know I can, this is like my safe haven. And if the costs were not as they are, I would use this balloon basically for every PCI where I use an NC balloon, because I think it's the best NC balloon. Mm-hmm. Because once you have tried the open NC balloon, you will find out that actually the other NC balloon are not really NC balloons, because it will just redefine your NC scale. Because until now you think, because the difference, if a semi-compliant balloon is here and a normal NC is here, the OPN is here in terms of non-compliance. This you experience because you look at the balloon, how it inflates in difficult circumstances. You will see that it always inflates like this. It never does the duck boning. And even if it does duck boning, it does sometimes, then you still see that the edges are not overstretched, but just the middle is not expanded. So it's a very safe balloon, and I think the important part is that we communicate with each other when we have cases, and feel free to reach out also to us and say, I had this difficult case. Can you explain why this went right or wrong? Because I think we still can learn from each other with this. And what I have learned maybe in the last years to combine it more. In the early years, I was maybe just trying to use just the OPN balloon. But I think now that we have so many different tools, I love to combine it, because achieving the best result is what I want from my patients.
I have a quick question for both Florim and Natalia. So, Natalia, you showed the use of the OPN for calcified nodules. And so, one of the theoretical concerns is that you inflate and the nodule basically shoots out and causes a hole. So can you talk a little bit more about the safety profile of using an OPN?
So I think even in nodules of calcium, depending, I like Florim's perspective about the lumen. You had a nodule that is really obstructing the lumen. I think now we have pretty good understanding that probably we want to do some ablation if we need to. The lumen is very, very small. But if your choice is to use an OPN NC, then you use a 2.5, right? Because if the lumen is very, very tight, you don't want to use a 4 and push the nodule like in the real adventitia. So it's more about the understanding of what you want to achieve. So you see a nodule really protruding, you use a 3.0, and maybe you display the nodule enough and you modify enough to put your stent.
And maybe just one point. Very often in nodular calcium, the perforation happens after the stent. You put the stent, you post-dilate, and then you have. And this happens because you use a way too big balloon in that circumstance. And I think for nodule, what I teach and preach is respect the nodule. And if you don't have to put a stent, don't put a stent and use a drug-coated balloon. But this is another topic, maybe next year with the next symposium.
Excuse me. Another question? Actually, to the point you mentioned, you would not know you have a nodule in most cases until you image. So that's another reason we say you should image. I know Natalia will be very happy for that, but if you don't image, you don't know, and then you can get in trouble when you don't understand the anatomy to start with. Yes.
When do you prefer this balloon over other calcium modification, modified lesion, over before cutting a scotic balloon? When do you prefer to start with this balloon, OPN balloon, before thinking in another calcium modification lesion like rota, like scoring or cutting balloon?
I don't know, Stephane, you want to tackle that? Or?
Well, I think when you have like a real rail calcium where it's very concentric and relatively focal, I think or or multiple areas where obviously you may be limited with the type of therapies, then I think these are great cases for using OPN. And I don't know what
There
Natalia,
is
you
some
think?
data that if the minimum lumen area is over 2.5, there is no sense to do atherectomy devices because you're not going to gain, you're not going to modify. So I think if your lumen is good enough to put a balloon technology, then you go with the OPN because it goes very easy. You will be surprised if basically you feel like putting an NC, but as Florim said, it's like a super high-end NC. So I will say based on lumen, you can decide that.
And Manos, I have a question. We were talking a lot about diameter. What about the length? Is it important? Are you stocking all the length of OPN? Are you using only the shortest one and you reinflate it multiple times? Does it matter?
For me, it doesn't matter. I'm now in the process of just getting one length from SIS Medical because, in my opinion, this theoretical advantage you have with to press just at one spot with a 10 mm balloon, in real life that never really played a role. So that's why I'm happy with 15 for everything. But maybe
I think it depends on your cath lab manager and how easy going they are. If they give you a lot of hard time, too many sizes, then you. But I mean, I think there are some benefits. I mean, sometimes you have a short focal lesion and you don't want to go too long. Some other times you have a long lesion and you prefer to get a 20, so you can do a couple of reinflations versus doing 5. But also to the point that they mentioned, you need a atherectomy when you can deliver, right? So atherectomy, as Stephane said, if you can deliver, that's on the SKY algorithm, that's when you do a atherectomy. If you can deliver, then you can go with the other modalities. But maybe one last question and then we close.
Start using OPN by Dr. Florim's influence past 1 year. It's doing wonders. So one question is, by imaging, can you predict which case you have to use OPN or which case you have to go for some other modalities like IVL or orbital atherectomy?
Well, and maybe I can answer that. So in my opinion, and this is, I know, very provocative, for me, IVL is a bailout therapy. So I never use IVL upfront. But there are other opinions, and the bad thing is that we don't have comparative data until we have the results of Victory trial, because you can ask 10 people and 10 people tell you a different opinion. But in my lab, and we use a very limited amount of IVL, OPN is the first therapy for calcium. And we combine the OPN then with different modalities. But OPN is always the center of the treatment.
Well, again, thank you everyone. I know it's past the time. Appreciate great discussions and a lot of learning. Thanks, everyone.
Thank you so much. Great.